I'm going to go ahead and get started. Welcome. My name is Keith Terry. I'm your host, and welcome to the Paul W. Caine Foundation and Terry Performance Group Family Health Webinar Series. Our topic for today, I'm excited about, is health inequities, advocating for life. And we have an esteemed panel of experts that are going to shed light on a very, very, very important topic. A couple of logistics for those folks that are going to be chiming in, listening and registered. You are in listen only mode. And if you have questions, please put them in the chat box at any time during this webinar. Again, like I said, my name is Keith Terry. I am your host. We are running live now on Facebook as well, if you want to listen there, but you can't put your questions in. And so what I'd like to do is just let you know that this is about the 12th webinar we've had on this series. I'd like to take a moment now and introduce the president of the Paul W. Caine Foundation, and that's Mr. Kevin Mott. And Kevin, take it away.
Good morning, Keith. Thank you. Good morning, everyone. Thank you for joining us. And thank you for supporting our Family Health Series. As Keith said, I'm the president of the Paul W. Caine Foundation. We are the 501c3 designated arm of the Evanston Alumni Chapter of Kappa Alpha Psi Fraternity. And, as Keith said, this is our 12th discussion. All of them have been fabulous. All of them have been well attended, and we appreciate your support. We appreciate the support of the guests, of the speakers that we've brought. And what we try to do with this is to cover topics that we think will help people in our family and people in our community lead their families and make decisions. And what we try to do is bring trusted experts to you to talk about very important topics. And my normal introduction is going to be a little different because, this is a topic that really touches me personally. And I'll tell you why. So in 2002, I was 32 years old. I was dealing with a lot of migraine headaches. And so I went to the doctor, and, doctor examines me, says, well, one thing is your blood pressure is extremely high. So we're going to focus on your blood pressure. And he, gives me different medications, and we try them. We try a few of them. None of them seem to work. And at one point, the doctor said to me, well, none of these drugs are really going to work as long as, you have so much fried food and canned goods in your diet. And I said, well, I really don't eat like that. I'm a person, I really like to cook. I cook most things from scratch. I'm very cognizant of what I eat. So, I said, well, that's not me. And he just kind of blew it off and said, yeah, well, cut down on the canned goods, cut down on the fried food. And at that point, I decided that, it seemed that this doctor was talking to me from a place of bias because we had never discussed my diet or anything like that at all. So I went to another doctor. Same thing, I'm having these migraines. Your blood pressure is very high. We got to get your blood pressure down. And we tried more meds. And at one point, this doctor said to me, he said, well, even if it was a long time ago, if you've used hard drugs like cocaine and things like that, they'll affect how, whether or not these drugs work for you. Once again, I said, well, where did that come from? Drug use is not something that we've ever discussed, and is not something I've ever done. So once again, I felt that, I was dealing with a doctor who was coming at me from a place of bias. So from there, I go to a third doctor. Same thing. I'm still having these migraines. My blood pressure is high. Let's try these drugs. Now, this one came a little differently, but at a certain point, he said to me, well, these drugs aren't going to work if you're doing HGH and taking steroids and things like that. Now, I work out, and I was in better shape then than I am now, but I didn't necessarily look like someone who was, spending so much time in the gym that I'm doing HGH and things like that. So I've gone to 3 doctors, nothing has worked. I'm at work one day and just having a horrible migraine. I call my HMO and say, I have to get into a doctor today. They said, well, the only doctor we can get you into today in your area is at a women's clinic. So I don't care. I just need to see a doctor. So I go to the doctor, and I'm at the women's clinic. And when I finally go in and we start talking, we had an actual discussion. It was the first time that I had had a discussion with the doctor at any point. And so at the end of my visit, I said to her, you know, if you obviously you didn't plan on having a lot of male patients, but if you don't mind, I would like to stay because no other doctor has actually engaged me in a conversation. And so I did. I stayed with her. We had the same issue. You know, my blood pressure was pretty high. It was very hard to control. We tried different drugs. They weren't working. But at one point, she said to me, based on what I know about you, it doesn't make sense that we're having such a hard time controlling your blood pressure. I want you to go to a nephrologist. And I didn't even know what a nephrologist was. So she referred me to a nephrologist. After doing some tests, you know, I was diagnosed with having FSGS, which is a rare form of kidney disease. Just for reference sake, the basketball player Alonzo Mourning, he also had been diagnosed with FSGS. My doctor told me that that's what's normal for people who have an FSGS diagnosis, is that within 2 years, you're going to be in need of a transplant and either doing dialysis or trying to get that transplant. And if you do nothing within 2 years, you know, you'll be in renal failure and you'll be dead. That's what's normal. And my experience was not that. My experience was much better than the average person. I made it until 2017. I was, and I didn't have to go on dialysis. And I was blessed to have a friend from college give me a kidney in 2017. And so since then, things have been going well for me. You know, I'm dealing with all the issues that come with transplant. My life is definitely a lot better today than it would have been. But I do often think about what would life be like for me if I had stayed with one of those first 3 doctors. I can honestly say, you know, I don't even know if I would be here today. I don't know if I would have been able to not be on dialysis. My entire life could have been completely changed, all because of the biases from some other doctor. So this is a topic that's very important to me. It's hard to keep yourself together. It's hard to reach your goals. It's hard to keep a family together if you aren't getting the proper care that you need for your health. So what we want to do today is we want to talk to you and let you listen to these experts who can talk to you about how do you make sure that when you are engaging with the healthcare system, that you are getting the treatment that you deserve. How do you make sure that the doctors that you have are respecting you as a person? And just how do you make sure that you can lead your family through these difficult things? Thank you all for joining us today. I think this is going to be a great conversation, and I want to say thank you to the speakers.
Thank you, Kevin. I appreciate that. Without further ado, I want to take this moment to introduce our panel of experts. Again, my name is Keith Terry. Logistically, put your questions in the chat box. You just heard Kevin talk a little bit about his journey dealing with the healthcare system, but I just want to read a couple of statistics for you. There's a National Institute of Minority Health and Health Disparities that talks about the impact of health inequities in the United States. And right now, we know that number is about $451 billion. We also know the impact of health inequities and how Black and Brown people have fared during the pandemic. And so this is a really important topic. My background is in healthcare, and I just wanted to take the moment right now to introduce our panel. Here is what's coming at you. I'm going to read their bios, and then I've asked each of them to spend 5 minutes talking about an area of this in this area, and then we're going to open it up for discussion. Without further ado, we have Dr. Jason L. Cummings. He's an endowed assistant professor of sociology at Loyola University, Chicago. Dr. Cummings obtained his PhD from Indiana University as a trained medical sociologist. His work investigates the socio-historical and present-day consequences of racism, racial privilege, racial stratification, and their manifold contribution to racial and ethnic differentials in health and well-being. His work is undergirded by two theoretical perspectives and span multiple areas, including interrogation. Number one, how racial and gender differences in health and well-being in the U.S. have changed since the 1970s, and the social, political, and economic origins of these changes in prior decades and during the post-recession/Obama era. Number two, whether racial misclassification or social assigned race, i.e., being perceived as white by others, influences the socioeconomic and health status of persons of color. And number three, the role racism, discrimination, and kidney transplants disparities. Dr. Cummings' work has been published in several journals, book chapters, including Research on Aging, Journal of Racial and Ethnic Disparities, Quality of Health Research, Life Research, International Journal of Equity and Health, and Journal of Happiness Studies. Welcome, Dr. Cummings. Next, we have Mr. Montrez Lucas, who is an LMSW. He is the Associate Director of Patient Navigation at NephCure. He joined NephCure in October of 2022 as the Associate Director of Patient Navigation. He is a licensed social worker who received both his bachelor's and master's degree from Florida State University. Montrez comes to NephCure with an extensive background in the field of health social services. Before coming to NephCure, he led a team of social workers at Emory Healthcare in Atlanta. Prior to this, he steps into a position with over a decade of social service experience, ranging from behavioral therapy for adolescents with autism to working with patients and families on hospice and those experience homelessness. In his role at NephCure, Montrez helps patients, caregivers, care partners navigate through the healthcare service system. He builds relationships with rare kidney disease patients and families to help them identify and to solve problems, locate resources, reduce health disparities, empower patients to get care they need, and support positive health behaviors and outcomes. In his daily work, he personalizes guidance to patients navigating their kidney disease, including assisting with healthcare access, school support, insurance, medication, assistance program, and more. Welcome, Montrez. Finally, we have Mr. James Ingram II, is a director of policy and alliance development at a healthcare biotech company. In this role, James works closely with minority health advocacy and health and professional medical communities and other relevant social and civic organizations to foster key partnerships and alignment on important minority health related topics. James has spent the majority of his professional career in government affairs and advocacy, including more than 15 years advocating on important topics such as cancer research, cancer survivorship, and working to address cancer health disparities in minority and other underserved communities. James currently serves on the board of directors for a national young adult cancer survivor organization in Baltimore City. He is a member of 100 Black Men of Maryland and a longstanding member of the world's greatest fraternity, Kappa Alpha Psi Fraternity Incorporated. Yo. James has a deep passion for helping to elevate the perspectives and the voices of the minority community. I am going to stop sharing my screen and just say welcome all of you to this panel. Like I said, I've asked them to give 5 minutes. So we're going to start with Dr. James L. Cummings. Go ahead, Mr. Cummings. Welcome you all first. You can say hello.
Hi, Keith. Hi, everybody.
Hey, hello.
Thank you
Glad
for
to be a
having
part of
me.
the panel today.
All right, great.
Good morning, everyone. And thank you for the invitation. I look forward. Can everyone see the screen?
Yes.
Awesome, awesome. So I wanted to talk briefly in the 5 minutes that I have about what is health equity, and give a primer of sorts. And so I wanted to start off talking about very briefly how I became interested in this field called medical sociology. When I was in graduate school, I was interested in this issue of quality of life and this question of post-civil rights. How have African Americans fared in the United States? Have things gotten better or things gotten worse? Looking at things like educational attainment and a livable wage, et cetera. And I wasn't so much interested in this topic of health. And one of my mentors, they said to me, Jason, if you're interested in the quality of life of African Americans, then what better question to ask than whether they are alive or well? Is there any other better measure of quality of life? And that took me on this journey where I began to make a connection between health and social justice.
Mm.
And so when I think about health, I want to frame at least my brief discussion on how health is a social justice issue. And I often think back at MLK in 1966, actually in Chicago, during a speech. He said, of all the forms of inequality, injustice in health is the most shocking and most inhumane because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the conscience of the nation. And so here, Dr. King identified in 1966 that perhaps there's no greater injustice than health inequity, and it's no more shocking because it is the most inhumane because it often results in physical death. And so when we think about health equity, what is health equity? Health equity really means everyone has a fair and just opportunity to be able to attain their highest level of health, optimal health. So when we think about children, we think about families and individuals. The question we should often ask is, are societal opportunities available so that individuals can live and have a full optimal health and quality of life? And when we think about this particular question, it's important for us to note that achieving this requires ongoing societal efforts to both address historical and contemporary injustices, overcome economic, social, and other obstacles to health, and also in terms of healthcare, and also eliminate preventable health disparities. So in terms of what types of disparities can be prevented by allowing there to be a just society. So when we think about health equity, the Centers of Disease Control and Prevention says that to achieve health equity, we must change the systems and also policies that have resulted in the generational injustices and give rise to racial and ethnic health disparities. And so one example, of course, of health inequality is maternal mortality. Or in other words, women across race and ethnicity, when they are in childbirth, who dies? And one thing that we know, as you can see in this chart, whether we're looking at total, the next panel, non-Hispanic Black women, non-Hispanic white women, and Hispanic women, that Black women are more than 2.5 times more likely in 2021, the light purple line, to die during childbirth than non-Hispanic white women. And what we know in terms of preventable deaths is that even when we take into account Black women who have, for example, a college degree, they die at childbirth at higher rates than white women with less than a high school diploma. So this just isn't about poverty, it's just not about education. But scholars have demonstrated that part of this is tied to how society is structured in terms of racism, the stress and strain that Black women often experience in everyday forms of racism, but also the extent to which doctors and physicians often don't take serious the concerns of Black women and Black women are often left with lower quality maternal care. Another example, which is in line with some of my research, is the example of end-stage kidney failure. And so if you think about, for example, the population of South Carolina, if we think about in the South, much of kidney failure disparities are largest. 62% of those who have end-stage kidney failure in the state of South Carolina are Black, 37% of them are white, although it's the case that 69% of the population is white and 27% are Black. And so when we think about end-stage kidney disease patients in South Carolina who are Black, they're half as likely as white patients to actually receive a kidney transplant. So here's a core question. What are the roots of health inequity, right? I think from different perspectives, we're all talking about this issue. So when we think about health inequity, sociologists like myself and public health scholars often argue that health inequity is structured or rooted rather in how society is structured and organized. So we think about heterosexism, sexism, classism, poverty, racism, ageism, other structural barriers to care, also the distribution of resources, that they often lead to inequality in employment, housing, healthcare, et cetera, and also how our neighborhoods and communities are organized. And they often lead to things like cancer, higher rates of depression, hypertension, diabetes, et cetera. We know, for example, in the city that I am in terms of Chicago, that African-American adults and also children have greater exposure and a higher burden of exposure to lead-based, a range of different lead-based issues when we think about lead in our water, also in terms of pollutants. Also, when we think about where dumps are across this country, overwhelmingly African-Americans are exposed to environmental issues. And that has nothing to do with behaviors in terms of whether you go to a doctor, et cetera. And so in other words, racism represents a complex system of stratification that structures and influences our lives by determining our resources, access to income or livable wage, education, wealth, prestige, and power. Also, the neighborhoods and communities in which we live, our responsibilities in the family, our job conditions, our occupational hazards, and also, of course, stress, pressures, hassles, discrimination, and other forms of racism on a day-to-day basis. And so, as I wrap up, what I would suggest as we're talking about advocacy is really a twofold approach. So first, we don't want to ignore, for example, when we think about self, family, and community, the importance of advocating for healthier lifestyles. So it's important in terms of diet, exercise, having healthy relationships. It's also important for us on an individual basis to advocate for healthcare seeking, preventative care, regular checkups, mental health therapy, which is tremendously important for African Americans, self-care, prioritizing self, also advocating for children. We think about access to education, school bullying, mental health, healthy lifestyles, relationships, and also in terms of aging adults, when we think about elder care and support. Those things are very important, but we also have to take into account, right, in terms of health inequity, the importance of institutional change. And so that looks like advocating for healthier communities, neighborhoods that are free from violence, where there's adequate community resources, fresh food and grocery stores, especially where there's food deserts or areas where communities don't have access to fresh foods, fruits and vegetables. Also advocating, again, for educational opportunities in the school system, advocating for economic power, so access to quality jobs and livable wages, and access to wealth, building, home ownership, and advocating for political power, which I believe ties all of those things in together. So political participation, activism, voting for politicians that prioritize the needs of the poor, persons of color, and also identifying the importance of coalition building. if we're to solve the issue of health inequity, we can't do it on our own, but having a multiracial, a multi-class based coalition is tremendously important. And so I have a range of different resources, but that's my time. And hopefully I was able to give you a few nuggets to think about. Thank you.
And thank you for that, Jason, Dr. Cummings. We're going to go to, if you could stop sharing your screen, that'd be great. Next, we're going to go to Montrez. And as Montrez is starting to share his screen, we're going to provide those resource links to the listening public. Take it away, Montrez. And as he's doing that, please visit the Paul W. Caine Foundation at www.paulwcainefoundation.org. I can share if need be.
That may help. Thanks, Keith.
Okay, great.
Thank you, Dr. Cummings. Your heart act to follow.
Go ahead. And I will go to the, there we go. Sorry.
You're okay.
There we go.
Hi, everyone. As Keith described, I have about 10 or 11 years in healthcare and social services mainly. And during that time, I saw just what we're discussing today. A lot of health inequity when it came to Black and Brown patients, as not only a Black man that was that problematic and was very difficult to witness, but also as a healthcare provider, it was also very difficult working for major corporations that often seem to benefit from these inequities. So in order to negate this, and in order for us, in my opinion, to receive more adequate care, to close that gap, we need to be empowered and activated. We're doing that at NephCure and rare kidney disease, but regardless of diagnosis, I think it can happen for us in general. Us being empowered and activated, regardless of our diagnosis, regardless of our healthcare settings, it really, really will allow for us to close the gap of inequity that we often and too often experience. So this is a literal guide with a few sassy hints to let you know what you need to say when you're in these settings so that you can really, really advocate for yourself and also your families. So when to and where to activate, the setting and the situation. So these are different healthcare environments that I've worked in or have been associated with, and I have seen the most inequity take place. Acute hospital admission, meaning any of your hospitals that are in your community, it's very important that once you go into these facilities, whether it be for yourself or your loved ones, that as a Black or Brown person, when in these facilities, you become activated, you are very keen on what's going on, and you're very aware of not only your surroundings, but also how the system works. Most of us are under the impression that hospitals make a lot of their money by keeping us longer and billing our insurances, when the harsh reality is that the more efficiently these hospitals discharge us, the more money they get, the more they're rewarded. So knowing that discharge starts day one, that's important. Day one, your discharge plan has already been written, regardless of your diagnosis, regardless of your condition, regardless of how you're doing, your discharge plan has already been written. You knowing that helps you lean in and start asking questions and start being eager. You or your family or friends or partners are leaning in day one and already asking those hard questions. What's the goal of care? What status am I in? I'm observation status. A lot of us don't know. We're in an observation status as opposed to a simple plain hospital admission. We receive different types of care. Our insurance is billed differently, and we qualify for different services once we're discharged. A lot of us don't know that, and because we don't know to ask, and thus we also fall victim to the system. That emergency room, as soon as you're in that emergency room, that's a critical point for all of us. Whether we are there for ourselves or our loved ones, once we go into that emergency room, we're the most vulnerable that we're going to be usually during our admission. And also our care is being decided for us. That history and physical that ER doctor writes from that first meeting with us sometimes dictates how we're treated throughout our stay. So us knowing information has been written about us knowing already what's the goal of care, day one, and also attending those care plan meetings that are often taking places without our knowledge. Those medical rounds in the morning, the doctor, the nurse, and the social worker meets about all of your care and you as a person and your family members as people and your support system every morning, usually, to decide on how they can efficiently discharge you. Without you knowing the content of that meeting or know what's going on at that meeting, you can't advocate for yourself. So you asking about what was discussed or asking if you or your loved one can attend is extremely important to activate you to ensure that you receive the best care possible. Rehabilitation admission.
Oh, sorry.
Thank you. A rehabilitation admission is unfortunately a likelihood for a lot of people. A lot of our elders break their hips regardless of race, but particularly in the Black and Brown community, we go to these rehab settings. We need to be able to pay attention to the setting, the accommodations that our mothers and our fathers and our grandfathers and our aunts and uncles and ourselves, what kind of care are we going to receive? What are the ratings for these facilities? Medicare rates these facilities pretty annually. And so from Medicare guidelines, are they meeting the mark? Have they gotten in trouble? Have they been in sanctions lately? So you can better choose and advocate for your family member, what rehabilitation center they go to, the care they receive, the accommodations that are going to be available, and also the amount of rehab they receive. Insurance dictates that. So a lot of these things are things that we need to make sure we pay attention to when moving from the hospital and into these settings. My favorite is probably the initial medical appointment. To me, this is almost like dating. You need to know right away, or you meet your primary care physician, if this is somebody that you want to be in a marriage with, because they're the gateway to you receiving the right referrals to specialties, as Kevin said earlier, like nephrologists, as well as cardiologists. You having a good rapport with them knowing your needs and what your expectations are extremely important. That way, they advocate for you when you can advocate for yourself, and also they have your best needs in thought and in interest when making decisions on referrals and also services and prescriptions. You don't want a primary care physician who is there to see you once a month for 10 minutes possibly and not really service you. You want someone who's going to think 2 and 3 steps ahead, who's going to be very honest with you and transparent about what you can do to better yourself, so that you can avoid going to places like acute hospitals and you can avoid being admitted to rehabilitation admissions in facilities. So that relationship is very important, and you knowing that they work for you. You're the consumer, they work for you, you can fire them, and you can move on to someone who better meets your needs. That relationship is probably the most important to me out of all of these different settings. And then specialty admission and appointments, meetings with things like nephrologists, kidney doctors, and cardiologists, knowing what services they provide, knowing about your labs and the results, understanding what your insurance covers. Some of these specialty doctors you may not like. Kevin had to go, 2-3 doctors before he probably met someone who really hurt him. That's very significant to know about second opinions. It's very significant and imperative that you know that your insurance oftentimes will cover second opinions. And oftentimes, a lot of insurance companies encourage them. They want to know what's really going on because they want to know what they have to pay for. So you asking those hard questions and you attending and following up with those specialty doctors and really sitting there with them and advocating for yourself is extremely important so that you can receive adequate care. We can go to the next slide, Keith.
Okay.
Knowing your insurance, this to me is extremely significant. Building a relationship with your insurance company. It's better to happen when you have commercial insurance because you do get things like care coordinators and social workers. A lot of us don't know that. So you calling your insurance company, go ahead and get your care coordinator on the phone, a social worker assigned to you so that you can have an advocate in-house so that you know what your insurance comes with, what it offers, the services it provides. A lot of us don't get a lot of those services because we don't know they exist. So by you speaking to your commercial insurance, whether that be a Blue Cross, a Aetna, a Cigna, a Humana, and knowing your care team that's assigned to you is extremely significant because it empowers you and activates you once you're in situations. You don't want to be in a situation where you're in a healthcare crisis and not know what your insurance covers. Knowing far before that makes you a better advocate for yourself or your family. And also Medicare, and knowing about open enrollment. It's usually around November 1st to the January following. That's kind of a dating scenario. Every insurance company wants you to pick them during that time. So let the best insurance company win and really ask those hard questions. Also, if you are unfunded, You okay, Kevin? Also, if you are unfunded or uninsured and entering healthcare facilities and spaces, please know that once you're in an acute setting, that hospital has a third-party contractor usually that comes in and they're trying to get you signed up for Medicaid. You following up with that and knowing that is very empowering because the hospital wants to get paid, but also you're going to need things after you leave the hospital. You're going to need prescriptions, you're going to need medications. So you following up with that Medicaid application that's initially filed when you're admitted to the hospital really, really helps out your healthcare trajectory leaving the hospital and post-acute. Okay, next one. How to become empowered, keywords, phrasing, and context. So these are some sample questions and some different things you can do. Ask questions in general. What does the diagnosis mean? What are the side effects of these medications? What are the side effects of this procedure that I'm going to receive? What's the goal of care? Make sure that your doctor, your surgeon, anyone who's connected to you medically has the same goals that you have before we move forward. That's important because it dictates what happens to you after said procedures or after said hospital stays and admissions. Challenge. It's very intimidating to be in healthcare facilities oftentimes, but it's important that you say things like, I would like a second opinion. Oftentimes, only doctors who have fragile egos get upset with that, and we have to allow them to be upset. And that's okay. I mean, it's up to you to advocate for yourself. So hurt someone's feelings every once in a while.
Right.
It may be life-saving. What are other options? And also, sometimes having to change doctors. Advocate for yourself. Tell them what you require. Please ensure that this method is taken. Before signing, I would like to review. Request meetings. Attend those meetings. Ask for meetings regularly so that your presence is felt, either yourself or your family member, so that they know that you have certain standards that need to be met. When are the care plan meetings? I would like a meeting with all disciplines. Asking for a meeting with every discipline at once is very important as well. And also request documentation and attend and visit consistently. When your mom, your dad, our grandmothers are in the hospitals, the best care is given to the patients that have most visibility from their family in those healthcare facilities.
Say that again.
I've always said it, it's like getting any other service in life. The more you ask, the more present you are, the better care that the one you love receives. Okay?
Perfect.
And empower and activate in general. Ask as many questions as you feel are needed. Learn and be a sponge. That comes from my mama, and she's gonna be so proud I said that, because it's always be a sponge, Montrez. But be a sponge. Learn as much as you can. Ask as much as you can. You may not be the favorite person ever, but you will be taken care of far better. The person you love will be taken care of far better. And of course, activate, as I already stated. Lean into that process. Lean into all the curiosity and really try to be present as possible. These are where we're most vulnerable as Black and Brown people, in those facilities, at those appointments, at admission, post-acute, meaning as soon as we're discharged, we're very, very vulnerable because a lot of times we don't know the services provided. They're not told to us, and we don't know to ask. And also insurance. Insurance is extremely stressful and very, very boring and not at all attractive. I can't stand it either. However, us knowing what's covered is extremely important to our healthcare outcomes because we know what insurance company to go with, we know who to appeal, we know how to fight for ourselves.
Perfect. Should I get going?
Yeah.
Okay.
And Dr. Cummings, I copied you. That MLK quote stuck out to me too a few nights ago. He already stated it, but it is extremely true and extremely valid and extremely important. And I agree with everything Dr. Cummings said about it and the conversation it sparks. And I think that's it for me.
Okay, well, thank you so much. I'm ready to get into this conversation. Next up, we have Mr. James Ingram II. Take it away, James.
Yeah, absolutely. Thank you very much for this opportunity. I will say a couple of things. It's humbling to be a part of this conversation. It's an important conversation for our community, and I will also add, coming behind these, I think, two phenomenal speakers, and is going to be tough. But at the same time, I realized I probably should have had a slide on MLK's quote too, because it is one of my favorites and so very important. And it's not something that I just use for the community, but I also bring in terms of my own, my household and my family as well, because it's so important that we never forget those important quotes So anyway, it's humbling to be here today, to be a part of this conversation. And what I want to do is just talk a little bit about advocacy in general, kind of building off what has already been shared, and talk a little bit about my journey to how I got here as well. And I think, I will add as well, I never thought about, as Professor Cummings had shared, as I think about healthcare and working in healthcare, never actually thought about working in this particular field. I was political science major in background in politics, and worked in local politics as well after finishing undergrad, and never really saw until after having an opportunity to spend more time in the healthcare field and understanding how healthcare is impacting my own family personally over those years. Really saw it as an important intersection between, policy and advocacy, and how we can take our personal experiences with healthcare, how we can take our family experiences with healthcare and our community experiences with healthcare, and also advocate for those particular opportunities, and recognizing that there are some communities, as we all know, as we talk about with this particular conversation, that continue to be disproportionately impacted by the system historically, and even what we're seeing contemporary times as well. So as Brother Terry noted, I worked for more than 15 years advocating on important topics in the field of cancer advocacy, working to advocate for federal funding for cancer research, more effective and less toxic treatments for cancer survivors. And I will also add what were two of my most important and passionate topics for me personally, as well as this journey of cancer survivorship and cancer disparities, and helping elevate, I think, the experiences and perspectives of those who've been touched by devastating diagnoses such as cancer, and really bringing a voice to the long-term and unique needs of cancer survivors. I spent more than a decade, close to 15 years or so, advocating on Capitol Hill for the unique needs of those that were touched by a devastating diagnosis by cancer, and really working to engage with the community, particularly Black and Brown communities, to help them understand how they can also play a role in not just helping advocate for institutional change, but also being engaged within their respective communities, and then at the same time having those same conversations at the kitchen table with their families as well. As Brother Terry mentioned as well, I'm currently working at a biotech company focusing on addressing some diseases that where there is a genetic predisposition and impacting our community as well. And I will tell you that a lot of the role that I have now, and even previously as well, has really worked to engage more with the minority health advocacy and professional community, and even working very closely with other entities within our community that we know are the trusted messengers for how we receive accurate information. Accurate, I will say again, because they are the trusted messengers and the voices. So there's a lot of work that I'm even currently doing with the Black Greek Letter organization community and the faith-based community as well. I certainly will say, as we all know on this call, health equity has become a hot topic and a phrase. I do think it's important. I think it's been certainly outlined and highlighted in the previous I think presentations that, we also have to push further than the typical conversations around health disparities and health equity, and bringing light to the issues and the challenges that continue to impact our ability to access the healthcare system. Those that we know as the historical and the contemporary challenges and injustices, but also, you've even heard as well, the social determinants of health, which is so important that we bring more light to, the importance of having access to healthy foods and jobs and education and adequate insufficient housing and technology and those types of things. So we know the disparities are still real. We know that the prevalence and mortality rates for chronic conditions are still alarming. Brother Cummings, when he alluded to the twofold layer of advocacy and highlighting the need to bring advocacy to many of these issues, I thought it was an important point. So I will tell you very quickly, and I know we need to get at the discussion. I will just add, now is the time for advocacy. It is no more important, I think, time than now for us to play a part, whether it's the self-advocacy, or it's the community advocacies, whether it's working to advocate to make institutional change, because as you've heard as well, health is a social justice issue. It continues to deeply impact our communities. So it starts with each of us. We all have a story to tell. We all have the ability to make a difference, and no story and no experience is certainly too small as part of that puzzle to advocating for and bringing change to our communities as it relates to healthcare and the importance of it for all of us. And lastly, I will add, I lost my father 5 years ago. And I thought that I had a passion for health advocacy before he passed away. But I will tell you now, it's not just even a heightened passion. for advocating for these issues that impact our community, particularly even Black men, I now see it as my responsibility. And so to carry that forward and make sure that even my son, who now is 4 years old and is the third, that he understands his responsibility as he gets older as it relates to advocacy and making a difference within our community. So I will stop there. I'm humbled to be a part of this conversation.
So all of you turn your mics on. So we're doing something different. We've asked our president of the foundation stay on, Mr. Kevin Mott, because he's passionate. He is a person that gave his own personal testimony. And so I want to engage in a conversation and ask this: where do we begin? This morning, I was having a conversation, this same conversation with my wife, and she's as passionate and had her own perspectives talking about it. And each of you have talked about advocacy. Dr. Cummings has talked about it. Where do we begin? Because what I don't want to do here is talk about the obvious. We all know health disparities is a real situation in the Black and brown communities. And so I hear talk about, food deserts. I hear talk about politics. I hear all those are true. But what's the first step? Because at the end of the day, James, you talked about losing your father. My heart goes out to you. I've lost a child. My question is, this is so deep. Where do we begin? And I'm going to open it up because it's a philosophical question. We're talking to our people, our folks, and let's go from that question. Anybody, just jump in. I'm the host here. You're the experts. You guys are on the battlefield.
Yeah, Keith, I'll start with that. I think the very first thing is making sure that people in our community understand the quality of healthcare they deserve to ask for. I'm in a unique position in that I grew up in a working class to working poor family, and then based on my job as a financial advisor, I have quite a few clients that are very well off. And I just remember the first couple of conversations I had with them, just about going, just catching up. Client had to get a knee replacement. Oh, when's your surgery? How's everything going? Oh, it's going to be great. I'm going to go see, Dr. Jones at Northwestern. He is the best left knee, low cartilage, medial tear doctor in the country, and I'm going to go see him. Had a similar conversation with a client who needed to go see a cardiologist, and I just thought, and I had pretty good healthcare. My father, worked my father had a union job. We had pretty decent healthcare. We had a $5 copay, but I did not even understand that you could request that level of care.
Wow.
So that's the first thing. I did not know that's what other people were getting. And I think most of the people that I know, we get sick, we go to a doctor. So one is getting us to understand the level of treatment that we should have. And I always encourage people to have communication as a very important thing with their doctor. Kevin, is thinking about the standard that you're setting.
Kevin, I'm sorry, I didn't want to cut you off.
No, I was going to say, and one thing I tell men in particular is, especially as we get older, I'm 53 years old, like, hey, we got to get comfortable with having uncomfortable conversations with your doctor. Expect a high level of care, and you need to go in there and be ready to say what you have to say and talk about everything with your doctor. So I think that's one area to start.
Well, Kevin brings up a really good point, that patients don't know what they have a right to. And that takes me to a conversation I had this morning with the wife talking about the Patient's Bill of Rights. I have been working in the healthcare field for a while, and I did not know that it was passed by Congress. And so what else do you guys have to say? This is, Dr. Cummings, Montrez, James, please chime in.
So one of the places that I ended with my talk was this piece about coalition building. And so I think this is particularly important. I think what we're doing is certainly a good first step in terms of awareness and knowledge. I think certainly we want to be aware, we want to have knowledge, and I think each of the panelists have certainly provided a place to start. But I think coalition building is particularly important. And I know some people are like, what's coalition building? Well, one thing is, who can we connect to make a difference in our community, right? In terms of some of the resources that we need and also knowledge. An obvious place, given, right, the centrality of the Black church for many African Americans, is one place, not the only place, but it's certainly one place in terms of asking ourselves, in terms of the places that we worship, or the communities that we're connected to, or community health centers, or organizations, whether it's the NAACP or whether Greek letter organization, to ask ourselves, what are these larger communities doing to make a difference, or organizations or churches or worship places to make a difference in the lives of Black and Brown people? And I think that's a good place, because we cannot do it on our own. And I think many of these places and organizations also, if brought together, have the ability to also have political power. And I think that's particularly important as a starting point, not the only solution, but something that I think we're all connected to some organization or place of worship where we have other people that we can connect to make a difference, a real difference in the lives of Black and Brown folks.
And you think so just to dive a little deeper on that, so you think having more political power will improve the health situation of Black and Brown people?
Absolutely. As a social justice issue, we often just think about health as kind of something that's isolated, but education policy is health policy. So, right, having quality access to education, having quality access to jobs. So job policy is health policy, right? Ensuring that more people have access to healthcare, right? So when we think about our neighborhood policy, anti-pollution policy is connected to health policy, right? So obviously, as a sociologist, I'm biased in terms of, right, health being rooted in society. But I think, just to say this point, and, others can chime in, is we often ask ourselves, well, how is the way in which our neighborhoods and communities are organized, how does it impact our health? It's often difficult for us to think about that, but it's easier for us to think about how the way in which some neighborhoods and communities are organized, that they promote health. So I'll use the example of suburbs, quality schools, quality jobs, access to supermarkets, places where people can walk, in terms of sidewalks, parks, free of pollution, et cetera. When we think about, right, people own their own homes, so people are connected, lower rates of violence. So the way in which communities and neighborhoods and cities are organized, and we know that this is historically rooted, they have the ability to promote or inhibit people's health and access to health care. I
agree with you, by the way. My role is to be a provocative host here. So Montrez and James, please chime into this discussion because you come from two different perspectives, and I'd love to hear what you guys have to say. Go anywhere you want. It's too large for me to control it, but chime in.
Sure. I mean, I really like Kevin's bringing up, Black men having more of these hard conversations amongst themselves. I think us holding one another accountable is extremely important. I was at an event earlier this week, and we were discussing health inequity, and also Black men in general, as well as Black women and the roles, kind of. And right away, one of the representatives were like, well, you need to appeal to Black women. She said it flat out. You got to appeal to Black women because we're the ones going to make our husbands and our uncles and our brothers go to the doctor. Well, to me, of course, that was problematic because in my mind, I'm like, we're not going to give a Black woman something else to do. Dear God, like on top of everything else. Now, now a 50-year-old man is telling his wife, make sure my appointment's set up, where she's like, I know he's not going to not do this, and what I did was, and what I contribute now is saying the tide is changing. I have been to events as a Black millennial and been the only person of color who ate pork or who ate meat, and I'm trying to give it up, but keep me in prayer. But it was so good to see all these Black young men who were controlling the narrative and discussing one another, regardless of educational level, regardless of who was blue collar or where they worked or what have you. They were all interested in exercise. They were all interested in what's going on with their bodies, how they feel. And granted, the diction and the verbiage was different based on educational level, but the conversation was happening. And I think us holding one another accountable, especially as Black men, and constantly starting that narrative and keep it moving forward, changes our whole community. We do not need to pass another buck to a Black woman to carry. That is far too much. And we have to be accountable for our own health, as Kevin has been for his, and as I'm sure you all are for you all's. I think it's very significant that as Black men, we set the example, we move forward with that narrative, and we carry that weight for our community as well.
So James, let me ask you a question and
Yeah,
get you involved in this. You used to, again, I'm sorry you lost your father and now you enhanced your advocacy. Is it because you found that the healthcare system didn't allow you to have a larger voice, or you saw a gaping hole? What increased your advocacy?
Yeah, I think it's on a few fronts. I think it's the gaping hole. I think it was the having the opportunity to really, for the first time, sit down. My father and I had always had a close relationship, but the one thing that was not close in terms of our connection was him talking about his health journey, right? Why was he missing doctor's appointments? Why was he, not taking better care of himself, not adhering to the medications that the doctors had prescribed? Why did he only want to see a Black provider? And all this, and some of those things made sense, but it became more apparent the last year of his life. Having more of the uncomfortable dialogue, sitting there and finally listening to a man who had to go through so much in terms of growing up in a racist, segregated, South, going to all Black schools, those types of things. It became more apparent to me why that vulnerability was not as open and obvious for him throughout those years. But that last year of his life, that vulnerability became more real. And so what I think about as well is our connection to each other. Like our healthcare journeys are all connected, right? What we're talking about today. So like there's a responsibility on my end to make sure that I understand his story, to help be a navigator for him, and not just kind of dismiss certain things, right? Helping, but also providing him the opportunity to meet him where he was, right? In terms of even understanding, like meeting him where he was is not going to be the same place where I'm going to be, and then and those types of things, because times have changed in certain facets, but still so much further to go. I think so what I also realized, and come back to your initial question around, where do we start? I think it's really what, it may sound simple, but like conversations like this are so important and so central, right? And then so I've met so many men, having private dialogues with them around their health and their inability to disclose their fears, their concerns. Again, maybe not wanting to turn it over to their wife or their female partner, whomever, whatever that may look like, but then sharing with me privately. And so there's more there that we have to build out and make more comfortable for them to bring that vulnerability to the table, to be able to have these discussions like we're having today, to help them understand and help us as a community understand why this is so important, and then what we can do to better support those that are struggling along the journey. And I think that piece there, in terms of oftentimes the system and the lack of compassion that gets shown, certain communities, like there's just so much there that I think opens up when we have these types of dialogue and we embrace each other, and also understand the importance of connection and helping navigate a journey that oftentimes becomes overwhelming as a patient to have to navigate on your own, right? And so yeah.
So let me ask this question to all of you. We've heard you say that we should have tough, uncomfortable conversations with the medical establishment. Is that because it's us disclosing a condition that we don't want to talk about, or is it tackling the unconscious bias that exists in the healthcare system? I don't really know where to begin, because Kevin, you had to go to several different doctors. Montrez, you're advocating for folks, and you just made me aware about all the stuff that happens in healthcare. James, you and your dad, Dr. Cummings, you looking at all the statistics. When you say advocate uncomfortable conversations, some folks you got to hit in the face with what you really mean. So what are you talking about?
Yeah, I'm sorry. Go ahead, Montrez.
Well, my answer to that is very blunt, because the majority does, and they get treated better. As a child of a parent who got really sick when I was in college, and I mean at 22, I was 22 years old going to grad school for social work, and my mother was diagnosed with schizoaffective disorder, and I'm her only child. I watched her be pulled into a facility and was completely blindsided, didn't know what to do. Well, there was this young white lady who you could hear her heels clacking, and the nurses would scurry about. And not that she was like this intimidating figure, but she came with those hard questions right away. And her mother got treated a lot better. And so the next day, I became her. I walked down with the same amount of confidence and was extremely adamant about that. I think the very blunt answer to hit people in the face with is to say, the majority does, and their standards are met. Now, granted, I'm not saying it's easy for us to do that. I know that. I'm not naive to that. But what I am saying is that we have to push more in that direction at this point, because we are losing one another prematurely because of these questions that we don't know to ask, but also because of the system's almost embedded a fear of us in advocating for self when in these vulnerable situations.
Yeah.
Kevin, you were going to say something?
Yeah, I was going to say, the uncomfortable conversations, having them with your doctor, especially for someone like me, where I was dealing with a chronic illness, and unfortunately dealing with an illness where we don't have a 10-step process on how we're going to deal with it. There's no cure, no designated treatments for my disease. So when I was dealing with my nephrologist, who I really did have good communication with, we were engaged in basically medicinal roulette, just trying drugs left and right all the time. And I've said to her, okay, well, you want me to try this drug? Let's talk about the side effects. I can't handle those side effects because I'm a financial advisor. One of the side effects of this is it's going to make me moody. I cannot be moody with my clients. That is not going to work. And then, at a certain point, she's recommending a drug, and what are the possible side effects? Well, the possible side effect is erectile dysfunction. I'm like, well, hold on, let's talk. And the first time one of these drugs came up, I said, okay, well, I want the Viagra and the Cialis prescription too. And she says, well, do you need it? I said, no, but it's better to need it and not have it. To have it and not need it than to need it and not have it, right? Because, and she, she's my nephrologist is an Asian lady. She's about my age. These are not the conversations she has with, all her patients or whatever. But it's like, hey, this is what's important to me. This is part of, if we talk, you're talking about keeping me around for life. Well, this is an important part of my life.
And Kevin, did you learn? How did you learn to advocate? Was it through NephCure, or was it a fight for survival?
It was, like I said, at 32, she's like, well, if you don't do anything about this, you'll probably be dead in 2 years.
Gotcha.
Mm-hmm.
So, every year past that, I'm trying to figure out, how do I keep this year going?
Gotcha.
How do I get to the next one? So I knew I needed to have, but then another example of that is after my transplant, I had gone to see, I was referred to a doctor who is considered the expert in high blood pressure, because I was still having a problem with my blood pressure. And he's a very big name in the field. And when I met with him, he asked me no questions. He didn't really address anything I brought up, and he made a couple of statements that made me feel like, I don't know that I'm not necessarily comfortable. I don't see the communication going. So I talked to another doctor that I was seeing at the time, who was about his same level in terms of prestige. And I said, well, do I really need to see this guy? Because I don't see what's so special at this point. because as far as I was concerned, this guy just recommended more blood pressure pills to me. And I said to my doctor, I said, well, wouldn't you eventually just tell me to do these blood pressure pills? I'm like, so I don't see why I have to get treatment from this guy where we don't have a communication. I don't see what he's doing that's special. That wasn't comfortable. And I'm sure that's not what happens to him often, but that was important to me. I mean, that's one thing that I've learned is I really need to be able to communicate with you back and forth. And I need you to have some understanding of who I am and how I handle things. Those are the things that are important.
I got it. So very powerful comments from all of you. So I want to ask James and Dr. Cummings, Jason, a question. Jason, you're dealing with data. You're doing primary research. And my question to you is, are people listening? And I'm not saying lay people. I'm saying when you present your information to the world, to powerful bodies, are they paying attention? And I kind of slide that over to you, James, since you're in policy and alliance for a biotech company. How does Dr. Cummings' data influence what you guys do from a research perspective? I mean, Dr. Cummings got the data. Data is powerful. And we've known unconscious bias is here, right? And so I hear you saying, I got to advocate for myself. But the healthcare system knows the bias exists, right? The pharmaceutical companies are solving problems, and my background is that. And so let's talk a few minutes about this part of it, because it's so big that I'd love for you guys to tell me what you see, because you're perched at a different place on the tree than I am in patients. So what do you guys say about that? And you don't have to talk, James, about your specific company, but about the industry per se.
So one of the things that data showing, a few things that we talked about so far, is one, and I think Montrez kind of also pointed this out a bit, is one, when we think about holding Black men, us accountable, more often than not, we're the ones that don't go to the doctors, right, for checkups. We're the ones that aren't having the conversations with doctors and physicians or getting therapy when we need it, especially when we experience trauma. And overwhelmingly, the burden does end up falling on Black women for being advocates, not just for themselves, for their partners and for their children, and also for their aging parents. And so that's a huge burden. And so certainly we need to step up to also, right, advocate for ourselves, but also our families. I think that's particularly important. And we can't just allow the burden to be on the women that are in our family or our female siblings to help care for aging parents. I think the other piece that the data showing, especially when we're thinking about chronic illnesses like kidney failure, and when we think about this issue of advocacy, right, Black and brown folks who have higher levels of education, we're a lot more adept at advocating for ourselves, right? But when it comes to people who are poor, Black and brown folks in rural areas, or folks who are older with lower levels of education, it's much more difficult for them to advocate for themselves, because oftentimes they don't just lack resources, but also knowledge and access. And so one of the things that I see, even in terms of some of my work in terms of interviewing end-stage kidney failure patients in the rural South, is that overwhelmingly they're saying that in their conversations with nephrologists and nurses and social workers, that they're overwhelmingly feeling like they're being talked down to or talked over, that they're given information or information is thrown at them, but they're often not explained. And so they're left confused, right? And so that is a huge issue to think about. This issue of advocacy isn't just race-based, but it's also class-based. And it's also based on region. And so it's complicated and multi-layered, but there's a lot of information that we know based on research, but oftentimes as it connects to policy, policy often takes a life of its own and has its own set of priorities that end up aligning more so with kind of white male narratives and white male priorities.
Gotcha.
Yeah, I think those are really good points. And I do think, I think those are really good points that Dr. Cummings made. I will say that I do think some of these conversations that are being taken, to various organizations and some of the data, I won't speak to the research, program perspective or individually, but I will say in terms of helping others understand the lived experiences of our communities, right? And why understanding the lived experiences of our communities is so important. Some of the narratives that existed for so long in terms of, what our community does or does not do. And I think, having honest and candid conversations with helping understand, why lack of housing impacts our healthcare, right? Or, lack of, healthy foods and those types of things. So those types of conversations are taking place more. Look, there's so much more that needs to be done in this space in terms of truly and compassionately understanding these lived experiences of our community. But I do think those conversations are being had. And I do think there are I think there's some movement taking place into, to programs and those types of things that help address this. It's going to take time. But I think then there's so much more that has to be done when it comes to that lived experience piece. And even as we talk about like cultural competency and those types of topics, even like, just compassion for various cultures and truly understanding, how cultures are unique and different, and better understanding what does it look like for us to engage and embrace cultures that respect the cultures that we're trying to reach. And those types of things and conversations are so important. Again, there's a lot of work that needs to be done. I want to go back to something that Dr. Cummings said, because I completely agree. The importance, and Montrez hit on it too, the importance of advocating, particularly men advocating for ourselves and for our families. That is so vital and so important. I will say, I think the advocacy is starting to happen more. I think these conversations that we're having, and particularly geared towards Black men and bringing Black men to the table for these discussions, is happening. I'm excited about it. There's a lot of work that needs to be done, but I am excited that these conversations are happening and that we're involving Black men to be a part of, kind of overhauling this system and playing a role, whatever that role looks like, whether it's institutional and kind of advocating on an institutional level, or just in your own communities or at the kitchen table. Again, one of the things that I started doing the past few years is just convening my large family on monthly conference calls and just talking about health. And if there's a designated day or a designated month to whether it's lupus awareness types of things, that we're having conversations and bringing facts to our family. There's a lot of, stigmas that exist. There's a lot of things that are unknown, within our own, but just like the more that we have these conversations and dialogue and helping people understand that these things exist, and you may have lost an aunt to something that you had no idea that actually took place. So the more we're talking about that and opening up those opportunities for particularly even Black men to be vulnerable and to share their story and to hear more about how they can impact.
Great. So Montrez, I want to come to you for a second, because you said something that sparked my interest, and that was that our community needs to have a better understanding and engagement with the insurance company. Can you explain that a little bit more? Because I would assume that there are folks out there that they have insurance, an HMO, a PPO, Medicaid, Medicare, and read the policy and assume that the policy is golden. And that doesn't appear to be your perspective. Maybe it is, maybe it isn't, but I didn't know about advocacy. Can you talk a little bit about what you mean there? Because that is just as important as self-advocacy.
Sure. I mean, and if anyone's listening who is in the hospital setting, they may get mad at me after this, so I may have to hide out. But one thing that I saw a lot of when I was in the hospital setting, a lot of older Black and brown people who had Medicare did not understand how it worked for us and how it worked in general. So you would have them at discharge day, 75-year-old Black woman who has fallen and come into the hospital with a broken hip, and she's not ready to discharge. It's just the doctor's opinion. The nurse may agree with her and say, I don't think this patient's ready. But the challenging of the doctor, and like I said earlier, sometimes the fragile ego that takes place, everyone was very intimidated to speak to this doctor. So this has been an anecdote showing how this woman was under the perception that she had to just go home, had no one at home to help take care of her, and nothing was prepared for her to go home. Home health had not been arranged. None of the medical equipment she would need to get around the house had been arranged. And she had decided not to go to rehab because of fear. I mean, due to a lot of things that Dr. Cummings discussed historically as well, that fear is warranted. So her not knowing that when you have an admission, you have Medicare to a hospital setting, you have the right to appeal your discharge. So meaning that Medicare reaches out, they have a third-party contractor usually named KeyPro. And what KeyPro does is they go through and review your medical chart and see if they agree with your doctor's discharge order, or if they don't agree with it and they agree in your favor. A lot of times when that was done, they did not agree with the doctor. So when that was rarely done, it really helped the patient. It pushed us as social workers come up with a better discharge plan for the patient, make sure support was in place, making sure home health services were in place, making sure the family was trained on how to take care of that patient. But the times when it doesn't happen, and these patients, mind you, they get this notice almost every 2 to 3 days. They don't know to look at it. It's being slipped on a table next to a meal tray.
You're absolutely right.
So my mom goes to the hospital. She would hate this, and I fought against her with it. We're pulling the discharge the first time to make sure that everything is together. We're prepared for you to go home and you have everything you need. Your medications, everything's filled. That's an example of us not knowing, so we don't know to ask. And so instead of surrendering right away, instead of us going bowed head and lowered tail and saying, okay, you win, we can push against. But I do think there's a knowledge deficit that we don't know, that no one's cared to teach us. So we fall victim far more times than not.
So, wow, I don't even know where to follow up with that one, because, you just taught me something about discharging and pushing back. Where do we go to get that knowledge? Because, Dr. Cummings, in your initial data set, you showed deliveries, and you said well-educated college-bound women are dying at a higher rate, right? So where does this knowledge come from? Because if you're unlearned, it's not because you want to be unlearned, it's just that you don't know. So, and I open it up to everyone. Kevin, if you want to jump in, please do so. But I find this to be fascinating because we all come from a different perspective. We're all perched on a tree at different places and we see different things. So I didn't know about some of these things. So let's tie it together because we have roughly less than 10 minutes.
Yeah, well, Montrez, I mean, what you just mentioned is amazing. My mother, the last couple of years of her life, was in and out of rehab places. Mm-hmm. And one of the biggest issues that we had, I mean, this was something that should have, just should have been common sense, but she was constantly getting discharged on Saturday without the meds that she needed to get through the week. So her meds weren't being ordered until Monday. So she really wasn't taking, a couple of times, she really wasn't taking her full set of meds until Tuesday. Right. And here I am, like I said, I'm in the health, I'm advocating for myself in the healthcare system. I had no idea of how to do this. I eventually hired a private person who did this, who managed somebody's health, hired that person just to help with the discharge. So, there's so much that we don't know about how to handle it, what to do. And then, my mom wasn't necessarily in the best place, so we didn't necessarily get the best treatment, or the best treatment wasn't always offered to us right away. We had to fight for it. So, I think it's important for us to all understand that it doesn't matter your education level. The healthcare system and navigating it is something that none of us innately know how to do it, and none of us, unless there's someone like you, Montrez, is taking a class in it.
Sure, I agree with you. I agree with you, Kevin. It's very unfortunate, but it is true. Knowing those things really does help. The theories are great and philosophy is amazing, but literally knowing the information is far more empowering and gets us better results.
Okay. I in the last 10 minutes, is there something you guys want to specifically say to the listening audience? I found this conversation to be pretty enlightening. I've learned some things about insurance. So, why don't we just go around, and if there are a few comments that you want to make about this, because it's so big, and people are in need. There are folks that are listening right now that would love your advice on where to go. And so why don't we start with James first, and then go Montrez, and then Dr. Cummings.
Okay.
Yeah, I'll just add quickly that that everyone has an opportunity to, when it comes to, don't sell yourself short in terms of what you can do to help make change and to advocate for yourself, your health, for the health of your family and for your community. One of the things, kind of listening, Kevin, we've talked a number of times around some of these topics, but I even think just listening to this discussion, the importance of, even as you go to the doctor, taking someone with you a lot of times to be able to kind of dissect, and digest some of the information, because I think about, even when I go to the doctor, there's so many different topics and things thrown at you, and there's this expectation everything that I don't, I can say that. And so I think the importance of taking someone with you to help navigate this system that it becomes more complex and complicated by, I think, the day and the hour, I think is important. But I just go back to my point of not short selling and short changing the ability to have an impact, to make a difference. I am just enormously grateful for this type of conversation here today on this Saturday, to be able to talk about some of these things. And I've learned a lot of things. I've been taking notes from just this discussion in general, and just being able to pull nuggets of different things I don't know, to be able to take back and apply, just not to just my personal journey, but being able to help my community. So this is important. So thank you.
Montrez?
Yeah, I think I'll leave everyone with the thought of, I think the time to play nice is a bit over. It's outdated and overrated. I think that us playing nice and passivity has no place any longer in our culture when it comes to our health. I'm not endorsing anyone going into a facility and being a bully or doing that, but I do think that catching more bees with honey theory is gone and it's outdated, and we've suffered a lot because of us being intimidated in these situations, in these vulnerable situations, and us not wanting to ask questions because of us being perceived sometimes as aggressive or angry or far too assertive. But if we start to do that, and we continue to do that, because I think it has been started, we continue to do this, we build more confidence within ourselves and within our culture and our community. And the expectation then changes for us amongst one another to ensure that we advocate for not only ourselves, but our families, so that the buck does not get past anyone else but us, and we hold that power in our own hands.
Perfect. Dr. Cummings?
Great. Well, I wanted to thank you all for the invite, and also this was an awesome panel. So I certainly appreciate the invitation, even as an academic. Being invited to these settings, I think, are pretty important, at least for me. So to your last question, Keith, of course, you were asking, what are some of the resources where people can go to get some knowledge, and I think that's particularly important. And I'll also give you slides if you want to offer that to people.
Please.
But a few places. NIH.gov, of course, the National Institute of Health has lots of information. CDC.gov also has great information. So this is the Centers of Disease and Control and Prevention. Also, the NIH website has the Patient Bill of Rights, both in English and also in Espanol. There's a number of health equity section, an entire section on CDC. Also, if you have apps, you can put the CDC app on your phone. There's a range of other health apps as well, which I think are particularly important. So there's different resources that I think certainly can be important for advocating for yourself and also building knowledge. And then the last thing that I'll say, as we are talking about advocacy, but also policy near the end, I was thinking about critical legal scholar Derek Bell. He has a term that's called interest convergence. And the idea of interest convergence is that in order for us to get health policy done in this context that benefits and speaks to the needs of Black and Brown folks, it's also important for not just this idea of a coalition building, but also that we make clear that our interests align with the interests of white folks, and because they're the ones that are in power, in order to get them to move on our concerns. And as I also said, in order for us to have power is particularly important, and to think about, right, this issue of healthcare inequity in a more general term. So as I said before, education policy is healthcare policy, right? Neighborhood community policy is healthcare policy. Environmental policy is healthcare policy. That every single policy we could possibly think of, including having a livable wage, all of that is connected to health and healthcare policy.
Amen. Kevin, you want to say a few words before I end it for us all tied together?
Keith, thank you as always for being an excellent moderator. I want to thank the panel. You know, I have been, one of the things I've been happiest about since we've done this, like I said, is just the quality of individuals who've been willing to come and give us a little bit of time on their Saturdays, and you guys knocked it out the box. So I really appreciate you. And to everybody listening in, I just want to say, just from my own experience, one, keep in mind that you deserve the highest quality of healthcare. You deserve physicians, healthcare professionals that communicate with you. You deserve professionals that listen to you. And finally, you know, early diagnosis can save your life. So, you know, I don't know a lot of the reasons why my experience with my disease went so much better than a lot of people had. But one thing I do think is I was diagnosed very early on. We caught it, you know, before the worst of it could happen. And the only way that you do that is by going to the doctor, getting your regular checkups, staying ahead of things. So whatever it is that you have to deal with, the earlier you can get diagnosed, the better. And that gives you better opportunity for better outcomes. So that's all I want to say. Thank you all for listening to us, and thanks for giving us some time today.
And I want to thank the panelists. Again, my name is Keith Terry. There's two things I want to say before I turn us away and let us have a great Saturday. Is you've heard from them, and we will be getting the information out, but I'd like for you all that are listening to me to go and look at the Patient Bill of Rights. I did not know that this was, I've learned a lot today. I did not know that this was something that was passed by Congress, and it really does tell us what your rights are. And I urge you to go and look at that document and advocate for yourselves based on that. You have healthcare rights, and I am asking you to please go and look at the Patient Bill of Rights. We should advocate, because if my mom's dying or dead, or my father or my son, or I die, then generational legacies are broken. And so I'm asking you all to stand up right now and to go out and advocate for yourself. Having said that, let me share with you one screen, because I really think it's important. The Paul W. Caine Foundation really does need your help. Please visit our website and take a peek at all of the other webinars we've had, all dedicated to Black men's health, all dedicated to family health. And it's at www.paulwcainfoundation.org. At the same time, we are asking you for your donations. This is a non-for-profit, and every dollar that we raise goes out to the community. And so I'm asking you to go and visit it. 1, for education, 2, to see what we're doing, 3, to give your dollars. And so I just wanted to sit here and just say thank you all for listening. Send this to people that you know, because, you know, education is power. And as you can tell, I love doing these. I love educating our people. And with that, I just want to say thank you, Dr. Jason L. Cummings, James Ingram II, Go Newt Yo-Yo, and Mr. Montrez Lucas. All I'm going to say to you is thank you. And Kevin, have a great day. It is Saturday, everybody. Go out and have fun. Tell somebody that you know you love them, because at the end of the day, life is not promised to us. We make it. And I just want to say thank you all and have a great Saturday, everybody. Take care.
Thank you, Keith. Thank you, Kevin.
Thank you.